Hello, everyone, and welcome to the Parkinson Performance Center podcast. I like to say that this is a platform where science meets humanity, for real, where knowledge is translated into something precise, something usable and tangible, bridging the gap between research and lived experiences for people with Parkinson's and their families, but also experts, clinicians, and practitioners. I am Gaia Forlani, your host and the co-founder of the Parkinson Performance Center. I want to immediately introduce today's guest, Dr. and Professor Francesca Morgante, Professor of Neurology and Safra Chair for the Study of Aging at the St. George's University of London, honorary consultant neurologist and leader of the Advanced Movement Disorder Therapy team. With over 180 peer-reviewed publications and a leading role in international research and editorial boards, her work continues to shape the scientific and clinical landscape of movement disorder and neuromodulation, advancing the understanding and treating of Parkinson's disease specifically as well. Now, today, this conversation will be grounded in science, but driven by a deeper purpose: to restore direction, to give you clarity, strength, and possibility in how few aspects of Parkinson's are understood and lived for all my listeners. With no further ado, Professor Francesca Morgante, welcome and thank you for joining me today.
Thanks, Gaia, for this opportunity, and I'm super delighted to join this intellectual coffee appointment. And I think that communication is really the main pillar of treatment of any medical condition, but in particular of treatment of people with Parkinson's disease. So I'm very happy to join today.
And we are indeed very happy to have you. I would like to also start immediately by letting our listeners know a little bit more about you. What first drove you to neurology, movement disorders, and Parkinson's? And then what specifically is your focus of research, but also clinical practice?
I've been always fascinated by the mechanism of the brain since studying neurophysiology in the early years of medical school. I really wanted to understand how movement abnormalities or sensory abnormalities, but also abnormalities of emotions and mood were produced by the brain. And the story, it's the typical story of many people that are involved in movement disorders. I was in my 5th year of medical school, and then we had a teaching session on Parkinson's disease. And for that teaching session, the professor invited a person with Parkinson's disease. And so this person was in the wearing off period, so their medication started to decline and had that very severe movement disorder, couldn't walk, could barely speak. And then he took his medication, and then we saw the miracle of levodopa. And that was quite a striking change for a medical student to witness. So I thought, well, this is really a field of neurology where I can treat the patient, I can do something. And then there is a second moment. It was my 6th year of medical school, and in my hospital, there was a surgery in a person with Parkinson that was still quite experimental because a very few centers were practicing that kind of surgery. And that surgery was the brain stimulation. And I joined the surgery. There was this awake person with Parkinson that was shaking a lot and he could barely move. And then I saw another miracle, the miracle of the brain stimulation. And that obviously opened the way to study Parkinson's disease and movement disorders.
Yeah, that's very nice. We will talk in depth about DBS, so deep brain stimulation, to explain also to our listeners what is it, why it's important. But let's start also, on a more deeper, scientific aspect. In simple terms, can you tell us what is happening in a brain of a person with PD? Many people get yearly diagnosed. We have currently more than 13 approximately million of people worldwide. So to give a little bit of insight, what is truly PD? Maybe also what is it not? Maybe there are some misconception to clarify. And I would like if you could please also explain why basal ganglia dysfunction and only dopaminergic neuronal loss are not the whole story here.
Well, Parkinson's disease it's really a complex disorder, and we're still trying to compose this puzzle. Initially was conceptualized as a lack, a deficiency of dopamine. This is a chemical substance, a neurotransmitter, we call it in medicine, that mediates many things in the brain. It mediates movement. It controls also emotions, but it also is involved in cognitive processing. So processing, for example, of memory retention or very high skilled cognitive functions. But then it was very clear from clinical observation that the disorder had several other symptoms that we call no-motor symptoms, like sleep problems, mood problems, and disorder of control of blood pressure, problems in the gastrointestinal symptoms. And that from the simple clinical observation prompt to study more in details the degeneration in the brain. So we understood that several systems in the brain, not only dopamine, that control these different functions, sleep, movement, regulation of blood pressure, regulation of gastrointestinal control, regulation of bladder, are involved in Parkinson. So in Parkinson disease, there is a degeneration that is progressive of this different group of neurons. But one of the key problems is that there are different subtypes. So what we call Parkinson might be indeed different diseases that we put under the umbrella of Parkinson, and this justify why people can have different pattern of progression, or they can manifest with a different package of symptoms. Some people, for example, they might have more involvement and problem with their walking. Some other people actually, they do quite well motor-wise, but they have more problem with their mood and cognitive function. Some other people, they might have more problem with blood pressure control and sleep. So the big challenge nowadays is understanding from the early phases of the disease some biomarkers, so some signals that can be some metrics that can indicate which type of progression patient can disclose.
Mm-hmm. Thank you so much for this. I think it's very important for people indeed who get immediately diagnosed to know that their path might be completely different from someone else, and not be scared, obviously, but learn that this heterogeneity, it's very complex to understand. Can you tell me also a little bit more about the neural mechanisms of Parkinson, and what does it mean when a person does some research on the neural mechanism? Why it's important? What can this tell us about the brain of a person with Parkinson's?
So what is the neural mechanism? So it's the neural mechanism, it's understanding how the brain, a different part of the brain, contribute to produce a certain manifestation of Parkinson. So we mentioned that Parkinson's, it's very much heterogeneous and includes different symptoms. So when we speak about the neural mechanism, so far we have some evidence. We have most of the evidence for what produces in the brain the slowness of movement, so bradykinesia. We have some evidence about the stiffness, but not complete. I mean, it's a limited number of studies. And also there are a group of studies that have been developed some theories on how tremor is generated. For example, it seems that the structures that are involved in the generation of tremor that patient called shaking in Parkinson disease are not necessarily the structures that are involved in the dopamine transmission, the basal ganglia, but actually, for example, tremor might be also produced by a circuit, so a group of fibers that connect the cerebellum with the part of the brain that control the movement. So it seems to be a more of a widespread problem that involves another structure and not necessarily the basal ganglia. So we have quite a bit of evidence about the mechanism, so the signals in the brain that are associated to some of these symptoms, but not just the signals, because it's not just about finding an abnormal wave and a normal signal. It's also understanding how different areas of the brain communicate. So the brain is connected, is highly connected. So in Parkinson's disease, there are different abnormalities of connectivity between brain areas. And this abnormal connectivity, for example, between the areas of the brain that program the movement and the areas of the brain that are involved in automatic control of the movement, that is a disconnection. The biggest gap is now try to understand what are the alterations in the brain, and not only in the brain, but also in the spinal cord, but also in the brain stem, but even in the muscle. And so which alteration are the basis for other symptoms of Parkinson's disease, such as, for example, stiffness. So stiffness, for example, might recognize more of a spinal problem. So the spinal cord, it's connected to the brain, and it's in the spinal canal, and where there are all the neurons that control the movement and the sensory perception. But also there are very important reflexes in the spinal cord that are important for standing up and also for controlling muscle tone. So is it possible that maybe like the stiffness in Parkinson is partly due to these spinal abnormalities? There are very old studies on that has been again reappraised. One of the hugest gap,
No, go ahead, please.
So one of the hugest gap actually is about mood and anxiety. So anxiety is one of the major symptoms of Parkinson. It affects mainly women with Parkinson. It might fluctuate. So people with Parkinson can take levodopa, and levodopa release their anxiety. And then in the wearing off phase, anxiety occur again. And sometimes people also have panic attack. They can also wake up in the middle of the night with different physical manifestation due to anxiety. Well, this symptom is quite obscure. We really don't know how it's generated in the brain. In our group, we have started to do some studies, and there are some hypotheses. For example, maybe there is an abnormal connectivity between areas that are involved in emotional control in the brain and the motor areas that might determine this anxiety. Maybe there is a specific signal in the brain that encodes anxiety. And this is very important to do these studies, because if we understand what causes that symptom in the brain, we can develop target therapies that treat this very bothersome symptom.
And there are other two types of motor symptoms that are relatively difficult to treat, are very troublesome, and that also are part of your expertise. I'm talking about dystonia and dyskinesia. I personally also, in our coaching for people with PD, people with dyskinesia are really affected often, and the quality of life goes down. So can you tell us also more about these other two symptoms?
Well, dyskinesia arises often from two main mechanisms. The first one is disease progression. So it's more frequent as longer is the disease. But this is not enough to explain dyskinesia. Also arises from the combination of the progressive degeneration of dopamine with over-medication state. And so over-treating patient unmask dyskinesia. The issue is that patients have a different threshold for dyskinesia. There are a group of people that have a so-called brittle response, so they develop dyskinesia with a very small dose of medication, and these are quite challenging to treat because if you reduce the dose of medication, they cannot function. And we really don't know what is happening in the brain. So we have done a study many years ago, and we have made theories that these people might have abnormal plasticity in their motor cortex that is associated to this type of dyskinesia. There is also another very frequent type of dyskinesia that arises from the need to increase medication more to try to treat the motor symptom of Parkinson. And this leads to an over-medication state causative of dyskinesia. So this is a very interesting scenario that is very frequent, that needs a little bit of a critical appraisal on how to treat people with Parkinson. And I changed my practice a lot by seeing many people with Parkinson over the years. I've been working with Parkinson for more than 20 years and seeing really a lot of patients. And also from doing studies. Very interestingly, people with anxiety, their motor symptoms often are not as severe as compared to other people with Parkinson, but they require an escalation of treatment because of the anxiety. So it's very important that we really understand if the escalation of treatment in Parkinson is needed or not, because you might prevent dyskinesia if you understand if the person with Parkinson really needs the escalation of treatment. So in this regard, physical exercise and also psychological intervention are very important, are crucial, because if you identify these people that have a worsening of Parkinson that is transitory due to alteration of anxiety and mood, you can use these two strategies to avoid escalation of treatment and prevent or delay dyskinesia.
And what about dystonia?
So dystonia often arises when the medication wears off, so when you have the lowest level of dopamine in the brain, and it's usually very painful and it affects the legs, the foot. It might arise early in the morning or in the middle of the night. So this is the most frequent dystonia. It's called off dystonia, and this might be treated by extending the duration of medication in Parkinson using, for example, medication that reduce the breakdown of dopamine in the brain, so they prolong the duration of levodopa between doses. Sometimes this is not enough, and so we need to consider other strategies. For example, botulinum toxin. It's a good strategy because it can be injected in this muscle, especially if you have only dystonia in the foot. This is quite reliable to be injected because it usually affects the same group of muscle, and it's a local treatment, so it doesn't interact with other medication. So it's a good strategy for people to access this treatment. However, sometimes we are not able to improve off dystonia with these pharmacological strategies, and we have to consider, we need to be open-minded and consider a little bit of other strategies. There can be also non-pharmacological intervention. There are some evidence from kinesiotape to be used to treat off dystonia. There is not much of evidence from randomized control trial, but there are case reports in which this strategy, together with physiotherapy, has helped. But when, this strategy is not effective and dystonia occur in the context of other symptoms that fluctuate, then it's time to consider device-aided therapies like infusion therapies or the brain stimulation, based obviously on the patient profile. Yeah, it's very interesting that the mechanism by which dystonia arises is quite obscure. So why some people, for example, manifest with dystonia in the off period, and why most of the other people manifest with bradykinesia and tremor, this is unknown. It's very interesting to note that often dystonia affects people with early onset Parkinson, so people that have onset of their symptom before age 50, what in the past we used to call young onset, and now we call early onset Parkinson. It's very frequent in this group of people, and can also be like an onset symptom. So at the beginning of the disease, they can have dystonia in the foot.
And coming back to the specific potential therapies, botulinum toxin, you mentioned also subcutaneous infusion therapies. How proactive can patient be with a neurologist? Meaning, can they actually ask, can we do this, what to know before asking? Or is it something that is better just to wait, and then if the doctor decides it's time, it's better to potentially go for it?
No, not at all. This is not a field where the doctor decides and patient is the passive subject. That has changed a lot. Hopefully, we are trying to train the new generation of neurologists to establish really an open relationship with their patient. So we always speak about empowering people with Parkinson. What does it mean, empowering? It's really quite of a gray areas, because empowering is not just providing on the web, on leaflet information that they can read. Empowering is having a neurologist that from the early phase provide information and educate the patient, train the patient. I think training is a better word. Train the patient to recognize their symptoms and knowing in advance the option. The idea that we shouldn't mention future treatment to Parkinson people because we don't want to them to be scared or to overthink about this treatment is very old approach. We need to have a systematic approach. We need to allow our patient to be knowledgeable and to get the right information. And in the current world, getting the right information is very difficult because we are bombed by several information and discriminating what is fake and what is true and what is reliable and what is something that it's really we need to believe is very difficult. So in this regard, this is a process that has to build up together with the relationship patient doctor, and patient needs to trust, but it's a mutual trust. You trust your patient because you are feedbacked for what they report to you, and the patient trusts the doctor because the doctor has built up a relationship based on truth, on an honest and transparent doctor-patient relationship.
That's beautiful to hear, and I resonate truly a lot with this because when I was trained as a young neuroscientist, my mentors would always tell me, the only expert about Parkinson are the people who live with the condition, and how to learn to listen to them, to ask questions, to train them and educate them. So that's what we also nowadays bring a lot indeed in our practice at the Parkinson Performance Center. But one question that I would then like to ask you, indeed to empower our people even more, is how would you start this relationship of mutual trust? When a person for the first time comes at a clinic and see for the first time a neurologist, how to establish from this first day this sort of mutual trust? Maybe you have example from your also practice specifically.
Well, it depends in which part of the journey they arrive to see us. Obviously, the diagnosis is a crucial point. There are crucial times in the Parkinson journey. So the first one is being diagnosed. So if we are responsible for delivering the diagnosis, this is really a time where the relationship is built up. So we pose a lot of attention now in delivering this diagnosis. I heard stories from several patients going for a consultation, not even knowing that there was a suspect of Parkinson, and then the neurologist just showing up and say, well, I saw you walking, you have Parkinson. So this is not the way to build up this relationship, because this is not showing the patient how good you are as a neurologist to recognize the disease. This is about delivering a diagnosis that is life-changing. Most of my patients say that before the time that I was told I have Parkinson, I was this person, and then after the time I am that person with Parkinson. So we need to avoid that the person feel that is the person with Parkinson. So Parkinson do not define them. So one of the major take-home messages that when neurologists deal with delivering the diagnosis, they really need to spend time and explain, and also use a scientific evidence to explain what is in pipeline in terms of scientific research, explaining the disease, treatment. Obviously, it's a shock. What in an ideal world, based on the resources in the health system, this cannot be just managed by a neurologist. This is how the trust is built. It's about engaging other figures that are partners. We don't like calling them caregivers. Partners are partners. They care, but they should stay as a partner. So we need to make sure that that person with Parkinson stay as a person and not become a patient, because they have to live a life together with Parkinson, not in spite of Parkinson. Then I usually try to demonstrate that they are able to do everything, also with the disease. So social prescribing, going and start physical activity, or being part of a group of people, not necessarily with Parkinson, that do art, that do exercise, they do whatever they like. That is crucial. But for some people, the diagnosis can be quite a shock. So these people need a psychological intervention. So once again, in an ideal world, we would need psychologists to work. So that is what builds trust. And also honesty builds trust. So when the neurologist does not know what to do, or does not know how to address, say simply, I don't understand. Please help me. Maybe I need to listen to you. No, please give me more information. So I think that show to the people with Parkinson that we are human, that we don't necessarily understand everything. What does not build trust is just a trial and error. We don't want that. We don't want to say, okay, I don't feel good, and then you start a medication, and after 1 month, but I don't feel good as well, another medication. That destroys trust.
Oh, there are many important points here. I agree also on the fact of empowering the partners and spouses or family. I also don't like to call them just caregiver, as I don't like to call, for example, people just patient. Like in my practice, we call them just participants or athlete. We even have a coaching monthly for spouses and families, really also to teach them what is PD and not, let's say, to avoid to be just a patient and a caregiver. So it fully resonated with me. For me, it's important to also through this podcast really try to give to people the understanding that they are allowed to ask questions. They are allowed to say, can we try something different with together, let's say, with a neurologist? Because I often see that people are even afraid, because the neurologist or the doctor in general is seen just that big authority, and it's almost inaccessible. So I really like what you just explained, and I hope that many of our colleagues and people will, as I immediately try to capture this and implement it in their life.
This is, if I can add on this, I think this is a very important point. This is really changing. There is an effort to change this. And there are different initiatives. And as I mentioned at the beginning of this podcast, communication is the basis of a successful life with Parkinson, bidirectional communication. I truly believe that many unnecessary changes in the medication can be avoided with the knowledge of symptoms, because often people is very afraid and they just seek help. And for the neurologist, it's very simple to say in 5 minutes, okay, you need to change treatment. But you really need somebody very experienced as a neurologist, as skilled, not to change the treatment rather than changing the treatment. It's more difficult not to change the treatment, because not to change the treatment requires time and also requires the ability to show to your patient that Parkinson's symptom can be variable, they can fluctuate, and not necessarily that change is linked to the disease progressing, but maybe to some event of your life. So these are people, okay? So even people without any neurological disease, they go through period that they have more fatigue because they don't sleep well, or they cannot function well mentally because they are depressed. So we need to recognize what in their life is changing their compensation and restore the compensation. This is why I truly believe that through education and communication, most of the time, you don't need to change the treatment, but you need just to define what has affected the change in their symptoms and treat that, the cause.
I have now a difficult question. I like to go also back and forth a little bit within this human side and back to science. What is the most fascinating thing that you have learned about the brain?
Well, I think that one of the most fascinating things that I learned not only from people with Parkinson, but also from people with dystonia, that is a movement disorder that can occur in Parkinson, but also can occur in isolated form, affecting, for example, the neck, is about compensations. How, like, the brain can overcome symptoms. This is the most fascinating, I think, an intriguing thing that I learned. People with Parkinson, for example, might have a freezing of gait, but in certain conditions they can run better than they can walk, or they can walk better side to side, but they have freezing in the forward walking. People with cervical dystonia, that is a disease that is determining involuntary movement of the head, and so people cannot control their head because the neck muscles are contracting. If they put their hands on like their head, on their cheek, they completely resolve this movement. So like there are certain conditions that completely revert the symptoms. People with Parkinson, their tremor is affected a lot by emotional control. So stress increases the tremor, but there are some intervention that control this emotion, that also suppress the tremor. So the way that the brain overcome some symptom, some abnormality, this is what I think the most fascinating. But we really don't know the neural mechanism. So what we need to understand is the neural mechanism, because if we understand the neural mechanism on how the brain can function normally, we can develop non-invasive strategies. They can be rehabilitation strategies, non-invasive neuromodulation strategies, external device-aided therapies to improve these symptoms.
I agree. I actually did also my internship in cueing compensation strategies for freezing of gait. So I absolutely agree that it's just fascinating. It all seems like a magic that the brain can still implement and do, and we just are still absolutely in oblivion what it's here happening. But yeah, it's very nice. Another question based on your expertise: DBS. What is it? When a person, also a newly diagnosed patient, learn about PD, learn about many of these strategies, they know or they heard there is something called DBS, but what is it for? Do they need it? Why?
So DBS is a deep brain stimulation, is a neuromodulation treatment that consists in a brain pacemaker. So people with Parkinson, but also with other movement disorders like dystonia and tremor, can be considered for deep brain stimulation when their quality of life is severe despite pharmacological intervention, and they cannot function well in their life. So this is considered in Parkinson after at least 5 years of disease, because we need to make sure that the diagnosis of Parkinson is correct. Sometimes it takes a longer time. Also, I would say that this time is needed even for people with Parkinson to understand their symptoms, because the success of the deep brain stimulation depends also from people with Parkinson being able to recognize their symptoms and these fluctuations of symptoms. So the main indication is to treat fluctuations or wearing off. So when the duration of levodopa becomes shorter, so like from 5 hours, 4 hours, 3 hours, On average, people that are considered for the brain stimulation, they have at least a duration of 3.5 hours, 4 hours, less than 4 hours between doses. And obviously their symptoms are severe enough because you can have a mild fluctuation, for example, a little tremor. This doesn't justify the brain stimulation. But if in your wearing of time, you cannot walk, you're very slow, you have dexterity problems, you have pain, because like that can be a fluctuating symptoms, and these affect your daily function. Like you cannot work, you cannot function socially, and your quality of life is affected, is when we consider the screening for the brain stimulation. That takes an extensive battery of tests and clinical examination, neuroimaging, like doing a brain scan, cognitive assessment, to find if that person is a candidate for the procedure.
Mm-hmm. And what are the... Sorry, go ahead.
So once we select these people with Parkinson for the brain stimulation, they can receive the procedure, but their journey has just started. And that involves programming this brain pacemaker to make sure that these fluctuations in the symptoms are controlled.
Mm-hmm. Are there any latest development or advancement in DBS?
Yes, there are many compared to the way we were doing the brain stimulation 25, 30 years ago, even 10 years ago. One of the there are two critical factors for the outcome of the brain stimulation. Indeed, maybe three. The first one is selecting the right patient. So this seems to be an easy task, but it's not, because with the knowledge of Parkinson, predicting how that patient will progress over the years is very difficult, and we don't have biological markers for that so far. We just rely on clinical features. The second factor is being accurate with the surgery, so implanting these leads in the brain that deliver the electrical therapy correctly. And that obviously has improved because with the modern technique of neuroimaging, the surgeons can be more refined, and also like they can be assisted by neurophysiology recording to be even more precise. And third, it's about programming the pacemaker. And programming this pacemaker has advanced a lot. Why? Because there are devices that allow to use different types of combination of parameters, so we can vary how intense is this stimulation. We can vary the pulse width, so like how the duration of the stimulation is strong, and we can vary the frequency. And there've been many experiments using low frequency stimulation rather than high frequency stimulation, or a combination of the two that is called interleaving, in which you combine like high frequency and low frequency. Another big development has been derived by many studies that have recorded from the brain, that are called local field potential recording, and that has translated actually in a deep brain stimulation product that allows to sense, so to record the signal from the brain. So in particular, there is one type of abnormal signal that is called beta power, that seems to be associated to slowness of movement. And so now there are new devices that allow to calibrate the stimulation based on sensing that signal. And last but not least, we have new leads that have a different point of stimulation. Originally, we had leads with 4 contacts. Now we have leads with 16 contacts. So we have the possibility to target different also part of the brain at the same time. And there is also big development on neuroimaging with connectomic. Connectomic is a field of neuroimaging that allows to understand how different areas of the brain are involved in determining a symptom. So thanks to this development, we have now the possibility to implant the leads not only in a specific nucleus, for example, the subthalamic nucleus, but targeting tracts that are associated more or less to a group of symptoms. Like, we can use the implant strategy to improve tremor, but at the same time improving dystonia using different contacts. So this is quite exciting, but also still kind of investigational because these new developments now are tested in clinical practice, and there are several studies that are trying to clarify how to adjust the settings for adaptive DBS in a way that can be easy because so far it takes a long time, and also sometimes this signal is not really very powerful, and so we cannot rely on the signal. On the other side, we have now integrated in our programming strategies the images of the patient, so we can really visualize where these leads are implanted rather than doing a trial and error programming, and so this can guide us in choosing a better way of programming.
That's very exciting indeed, of course, to be cautious, and a lot is still to come. Do you think there are also other gaps in current Parkinson care that you are maybe a little bit worried about, or at the opposite, that, as I change completely also the field, and so looking more in a positive direction?
There are many gaps, but we need to be positive. The main gap is really understanding, using and also technology, how we can still assist these people outside of the hospital. So they come to the hospital, and depending on the health system, they are seen 15 minutes once a year, or 1 hour several times. That actually it's a rare situation. Most of the people are seen for a short consultation once a year. So one of the hugest gap is developing a way of monitoring and assisting people with Parkinson when they're not in the hospital, so they are living their life. Parkinson nurses are important components of the team. They're not available in all countries, where disease disfigure is a great liaison between the person with Parkinson and the neurologist. It's not enough. There are several figures that work with people with Parkinson in their life, like personal trainers, physiotherapists, psychologists, speech therapists, depending on their needs. So there is no system that integrates these figures in the health system. So this is one of the hugest challenges, and can be really life-changing for the majority of people with Parkinson, because more or less they feel abandoned. That is the problem. They feel abandoned. They feel abandoned by the society. They feel abandoned by their neurologist. They feel abandoned by their partners. So to restore the role in life, it's really a social intervention that conjugate, the care in the hospital with the care outside of the hospital. I think this is one of the hugest challenges, a hugest gap that can be resolved in the future. Obviously, there is another huge challenge, that is finding and disease-modifying therapy. And we're working on that. There is a huge effort, several groups in the world with clinical trials that are in this moment testing different targets for modifying the course of the disease. We know more about Parkinson. We know that there are different mechanisms. Sometimes there are people that have genetic variants that are risk factors for Parkinson. So there are trials that are targeting the product of these genetic variants to allow this product to work better. There are other attempts to restore the function of neurons using, for example, stem cells. So this is really very early studies that came out last year that we need to be cautious. But these are very well designed studies that will provide lots of data in the next years. And there are also other attempts using also physical exercise. There are very serious clinical trials that are trying to prove that in people at risk for Parkinson that do not have the disease, using a systematic and intense aerobic physical exercise program, you can actually delay or prevent Parkinson's disease. So we are here to deal with these gaps and challenges.
Yeah, I fully feel specifically the first, let's say, challenge and gap that you mentioned, because when I was myself in the clinic as a young neuroscientist, I myself was frustrated that these people were coming in just, here's the medication, see you in 6 or let's say next year, let's try to be proactive, but without real support in daily life, as you said. So we also, as like the Parkinson Performance Center, we really are trying to coach them daily, what to do, how, why, how much, everything, because that support in daily life means a lot to people that otherwise from one day to the other feel like their life is changing. So I'm grateful that you mentioned this point, because I think that sometimes people themselves also do not really understand the gaps, and then they blame too much the system, but not understanding that it's not also the fault of all the amazing doctors that are doing the work. So it's important. You told us about physical exercise and how important it is, but I would like to let know our listeners how involved you are at the front line. So can you tell us about your project as Swim for Parkinson's, the Parkathlon, even Parkinson retreats?
Well, I've been literally attracted in this world to treat Parkinson's disease and also to advocate for the importance of physical exercise many years ago from a colleague in Italy. His name is Nicola Modugno, and he was the one that created many of these initiatives, starting from a theater for Parkinson, and then another important initiative that is called Sail for Parkinson. Is essentially like a Parkinson retreat in which physical exercise, aquatic physical exercise, is complemented with heart therapy and also psychological support. He started to do this initiative more than 20 years ago, and I remember as a young neurologist, I was looking to him like somebody that was coming from another planet, because nobody was treating Parkinson like that. Then, more and more, I started to implement physical exercise in my practice, and I saw the huge impact. So many years ago, it was 2017, I received an email from a young woman with Parkinson. Her name is Cecilia, and she wrote to me and she said, "Oh well, I had the brain stimulation 6 months ago. I am from northern Italy, and I used to swim when I was a young person before Parkinson. I used to compete. And since I feel good, to celebrate my brain stimulation, I would like to swim on the Strait of Messina. The Strait of Messina is the sea that divides mainland Italy from Sicily. I am from Messina. I live in London, but my home city is Messina." And she wrote me, "I contacted you because you are from Messina, and I need a neurologist that is coming with me in this journey. Do you want to come?" And I never met her. I said, "Yes, I will come." And so we met and we crossed the strait. I was on a boat and I was the neurologist on the boat. And then she did it. She did it together with her friends. She was the first person with Parkinson to cross the strait. And then after a few months, I invited Cecilia in this event that I designed in Italy for people with Parkinson that was called Parkinson Body and Soul. And this was quite an extraordinary meeting, because never in Italy there was a meeting that was dedicated to people with Parkinson. As a part of this educational process with my other colleagues, we thought, well, we should do something for them to explain about Parkinson. And then during one session, Cecilia was invited to talk about her experience going through the Strait of Messina. She actually invited other patients, say, "Well, we should do together this next year all together. Who comes with me?" And I say, well, let's do Swim for Parkinson. Let's do this as a structured event to raise awareness about the importance of physical exercise, but not only, about also team working, neurologists and people with Parkinson. And so we started this journey, and we have done 5 times, and with increasing number of people. The last time it was 30 people, was 19 people with Parkinson, and then 11 healthcare professionals, neurologists, psychologists, partners, and we swam together open water in Strait of Messina, and we started to do and to want to develop more of this event to be more inclusive, because for safety reason, swimming across Strait of Messina, that is quite a challenge, it's 4 kilometers, cannot be done for more than 30 people, but it was huge because it went on national TV, and a lot of people with Parkinson saw these, they were also like people that were like in their 60 that did it. It was not just for young people. And so they felt empowered, say, well, if they have done, I can do. We wanted to demonstrate that you can do everything. But then with my colleagues, Maria Chiara Sensi in Italy and Nicola Modugno, we thought we need to do something that is more inclusive, and we thought about Parkithlon. So Parkithlon we did it last year in Abruzzo and involved 120 people. The oldest participant was 88 years old, a person with Parkinson, age 88, and we did an adapted triathlon for Parkinson with 400 meters swimming, 5 kilometers cycling, and then 3 kilometers walking. It was great because once again, it was a magic moment. Is where actually these barriers, doctors, patient is completely broken. We are just people learning from each other, and I feel very privileged because spending so much time with them outside of the hospital really has taught me what is this condition. I didn't learn that by seeing them in my clinic. Yes, I see them in my clinic, I listen to them, but spending the time, living their life, talking to them outside of the hospital in this event is really teaching me day by day what is Parkinson, what we should do as researchers, because it's a huge responsibility. What we are searching is to benefit people with Parkinson, is not to publish papers. And this is the main teaching point that I had from all these patient doctors event done and developed together.
Well, this is truly inspirational. It inspires me to even join you. I'm half Italian myself, so it's beautiful to think, well, why not?
You should enjoy. I mean, like now, this year there's going to be Parkithlon in Abruzzo in September, led by my colleague Maria Chiara Sensi, that she's a strong advocate. She's a neurologist, but strong advocate of physical exercise. You should join us, but also we should think to something that is on bigger, like what we want to do, involve more people, be more inclusive. We have seen in Netherlands, Bas Bloom organizing very similar events with cycling, raising funding for Parkinson research. We did the same in Italy, but ultimately all these events, they aim to show people with Parkinson outside there that they feel isolated, that they can do everything. It's really, we talk about compensations, we talk about overcoming symptoms and barrier. This is what these events are designed for, to demonstrate this. So we should do it together.
Beautiful. Yeah, that's absolutely beautiful. Let's do it. I'm absolutely in. We also came to the end of this podcast. Is there anything else you want to add, maybe for our listeners, to give them some hope or strength, or any take-home message that you would like them to know?
So what I would like to say is that don't give up, don't feel lonely, you are not alone. I understand that very often neurologists can be in a rush and you don't feel listened, but you need to find your strength by other people with Parkinson that manage to live with it. And this is why it's very important to attend groups outside of the hospital, to also being engaged in groups of physical exercise, not necessarily attended by people with Parkinson, because they allow you to feel that you can do everything, but also try to do things that make you happy. Sometimes I would like to prescribe happiness. I always say you are obliged to be happy with this condition, because if you're happy, your symptoms are less intense. And they tell me, like, no, I forget about my disease when I am happy. Obviously, it's very difficult to be happy all your life, but allow people around you to be happy. Choose what make you feel happy. It's a difficult diagnosis, but also give you the opportunity to make a decision for your future life and say, well, I need to change my life to live well with this Parkinson's disease.
Professor Morgante, thank you so much for this conversation, for being part of this podcast today. I learned myself a lot. I think I will take many, let's say, pearls out of this conversation. I'm sure also our listeners learned a lot as well. And for all of you, for all our audience, if this episode brought clarity, insight, or a new perspective, well, this is precisely why we are here.